السلام عليكم دكتور نادر.
عليكم السلام ورحمة.
إن شاء الله تكون
هلا.
بخير.
الحمد لله بخير، كيفك مرة؟ إن شاء الله بخير.
الحمد لله تمام.
الحمد لله. كيف الابلكيشن بروسيس بتاعك؟
والله الحمد لله so far so good. يعني recently the ERS has been silent I believe for many people anyway. لكن hopefully things change إن شاء الله.
إن شاء الله. Hopefully you'll hear good news soon. It's gonna be holidays, so maybe it's gonna be slow.
Yeah.
Hello everyone.
أهلا. عليكم السلام ورحمة الله.
We're all doing well.
خالد. Very good. الحمد لله.
أهلا خالد.
وائل. السلام عليكم.
عليكم.
Good morning ربابة.
عليكم السلام.
عليكم السلام ورحمة.
السلام عليكم دكتور نادر.
هلا. عليكم السلام ورحمة. وائل بيه، كيف أخبارك؟
الحمد لله رب العالمين. مروة.
Hello Sumi.
Hi, Dr. Nadir. Good morning. How are you?
Very good, thanks. Good morning. Good morning, Lubaba.
Good morning. How are you?
Very good, alhamdulillah. How are you?
Good, good. Alhamdulillah. Shukrillah. Thanks.
Good. Any news, Sumi, Lubaba, Khalid, or Wael?
No.
That's all right.
Yeah.
No news is good news so far.
Hopefully, yeah. This is our motto.
Yeah. I just told Marwa maybe in the coming days, inshallah, you will hear good news.
Hopefully, inshallah.
Assalamu alaikum, Dr. Nader, and everyone.
Alaikum salam wa rahmatullah. How are you?
Alhamdulillah, I'm fine. How are you?
Very good, very good. Thanks.
Still, there is no updates.
That's all right. Inshallah, soon you will hear good news.
Inshallah.
So the other good news, we met with the statistic center people at MSU, and they are very helpful. So we will send them the data for the abstract about the depression, antipsychotic, anti-anxiety medications, and hopefully we can get the results out back to the committee.
Yeah, that would be very helpful. Yeah. Most likely by Monday, inshallah.
Inshallah.
We just have a little problem with the data from Porsham Health, or how you pronounce it. Yeah. So there is overlapping on the reporting period. Like, for example, we do have a PDF from 2018, I think November until March of 2019. So we did not enter that data. We want to just clarify how we're going to proceed with that. And the other thing, we are waiting for Diamondale. I saw that you shared yesterday the PDF with the statistic team, but we haven't received it from you yet.
Yeah, so I need to access, they put it in that drive. So I was driving myself, so
that's okay.
But I will update you guys hopefully after the meeting.
Sure. That's good, yeah, but I don't think it would take time to enter the data. So far, we
sounds good.
Half of it, yeah.
Excellent, excellent. And the sheet and the app, no issues so far?
So far, I entered for HALT. I think the antipsychotic medication and everything went well, but I think my colleague previously and I experienced that when we put the month, for example, if it is May, it will end up like 1 to 5 or 1 to 4. So So that's why we need to go back to the Excel sheet and just correct.
Sounds good.
Piece, yeah.
Sounds good.
Otherwise, going well. Yeah.
Excellent. Thank you. Assalamu alaikum, Ryan. How are you? You are muted.
You're muted, Raya.
So
Yeah.
Ryan will present something today. How are you?
I'm doing good. How about you?
Very good. Thank you.
I hope everyone else is doing well. Yeah.
So far, yeah, they are doing great. So excellent.
Yeah, I will be presenting the role of the gut microbiota and immune system in autism.
Okay. If there is no questions, when you are ready, please go ahead.
Yeah, I am
Do you
ready.
want to share the screen?
Yeah, sure.
Let me just add you here. Where is participant? Try it now.
Okay, I think this should be good. Okay. So this is my latest research. It's about the role of the gut microbiota and the immune system in the development of autism. First, we'll give a brief talk about the background of the disease, autism spectrum disorder. It are neurodevelopmental disorders that present with social skills and communication challenges, restricted interest, and repetitive behavior. The specific cause of autism is not yet well understood. However, numerous researches indicated that environmental and genetic factors and dysregulated immune response and alteration of the balance of the gut microbiota could be implemented in the development of autism. Okay. Yeah, so we will talk about the gut microbiota. Compared to other body areas, the gut has a more significant number of microorganisms, and it could be more than 1 trillion with various species. Altered gut microbiome composition is called dysbiosis. It is associated with many inflammatory diseases, obesity, autoimmune diseases, and cancers. There are numerous communication pathways between the gut and the brain through the short-chain fatty acids, immune system, and vagus nerve. So any imbalance in the gut microbiota could affect these pathways and modulate brain functions and result in neuropsychiatric disorders. Gut microbiota is necessary to maintain the digestive system's physiological state. Alteration of the intestinal flora has been associated with autism. So human and animal researches all indicated that evidence from animal models illustrated that specific microbial shifts in digestive tract may result in challenges similar to the clinical picture of autism, with suggested mechanism involving immunological and metabolic aberrations and abnormalities in the fermentation process or toxin production. So when they changed the gut microbiota in animals, they found out the same clinical picture of autism. When they made these researches in human, investigation shows a microbial shifts in the digestive tract of children with autism. So many researchers compared the gut microbiota between autistic children, their siblings, and controls. And sometimes they investigated by using the PCR test for stool samples or something like that. So my research was a literature review. I reviewed a lot of researches, and one of them was Tomova et al. They investigated fecal microbiota changes and frequently existing digestive tract disorders in children with autism. What they did, they examined fecal microflora of 10 children with autism, 9 siblings, and 10 healthy controlled children by real-time PCR. Autistic children, fecal microbiota express a considerable reduction of Bacteroid firmicutes ratio, an increase in the lactobacillus species. So they found that there is change in the balance of the gut microbiota or the gut microorganism. There is less value or less amount of bacteroidetes and increase in the lactobacillus and increase in the incidence of these salvovibrous species in autistic children, and critical positive association between the severity of the gastrointestinal tract dysfunction and the severity of autism. Understanding the molecular and cellular modification co-occurring with this dysbiosis might help developing new treatment approach. That's why we should know, and we have to make researches to find out the specific change that happen in the gut microbiota in autism or children with autism. That's how we can develop new treatment approaches. The priority could be, maybe we could reestablish the gut microorganism diversity by introducing certain microbes or fecal transplant therapy, or using specific drugs like an antibiotic or probiotics. So that's what about the gut microbiota. I will just give a brief talk about the immune system itself. Researchers also reported that there is some inflammatory cytokines plasma level were higher in autistic children with a notable amount of tumor necrotic factor, TNF-alpha, interleukin 8, and interleukin 6. So they found higher inflammatory cytokines, which is understandable, but they also found elevation of some anti-inflammatory cytokines, like the interleukin 4 and interleukin 10 in children with autism. This could be targeted area to manage autism and provide better developmental outcome. However, it is not yet clear if the gut microbiota treatment and the blunt of inflammatory cytokine signal scores could treat autism. More research is needed to elaborate on that. So I thought I should also talk briefly about Alzheimer and the gut microbiota, as we are caring about geriatric most in this fellowship. Alzheimer's disease, the most common form of dementia, it's a neurodegenerative disorder associated with impaired cognition and cerebral accumulation of amyloid beta peptides. Studies in germ-free animals and animal exposed to pathogenic microbial infection or animal with fecal microbial transplant, they all suggested that there is a role for the gut microbiota in host cognition and in Alzheimer's disease-related pathogenesis. The increased permeability of the gut, and so how the gut microbiota or the dysbiosis cause Alzheimer. They found out that dysbiosis increased the permeability of the gut and blood-brain barrier. And that's how it affects Alzheimer's disease pathogenesis and even other neurodegenerative disorders, especially those associated with aging. In addition, bacterial populating the gut microbiota can secrete large amount of amyloid and liposaccharides. As we said here, Alzheimer is caused by cerebral accumulation of amyloid. So they found out that the gut microbiota can secrete large amount of amyloid and lipopolysaccharides, which might contribute to the modulation of signaling pathway and the production of pro-inflammatory cytokines associated with the pathogenesis of autism, of Alzheimer's disease. So even in the relationship of the gut microbiota and autism, I didn't mention here, but they found out that the gut microbiota can cause autism by interacting with the immune system. And the same thing here in Alzheimer. The gut microbiota itself could increase the blood-brain barrier and cause Alzheimer's. But the gut microbiota also could modulate the signaling pathway and interact with the pro-inflammatory cytokines to cause Alzheimer's disease. This is the resources or references that I used for my presentation. Thank you.
That's really excellent, excellent presentation. Thank you so much, Rayan.
You're welcome.
Any other questions from the group to Rayan, or any comments or addition?
I would like to thank Ryan for the great presentation. And yeah, it was very interesting, and the pros about it. First of all, mashallah, it's the transitional slides, enjoyable. She cared to explain a lot about the details about the research and the correlation between Alzheimer's and microbiota. So yeah, that's very interesting points. But I want to ask about what is the base of the research here? What is the method? And yeah, we want to understand the basis of this research. And thank you.
My research, it was a literature review, but the articles that I reviewed were most of them trials. Trials in which they examined the school of autistic children and their siblings and control, and just make a comparison between the findings.
Oh, it is great. Thank you very much.
You're welcome.
Thank you, Mulham, for the question, and thanks, Rayan, for excellent presentation and elaboration. Any other questions?
Thanks, Ryan. This is like very interesting topic. And so I was wondering that when I was attending a conference, I think from Family Medicine Department of MSU, so they are talking about the role of gut microbiota for COVID-19 actually. So they found the people who have like the way you explain, like dysbiosis, I guess, like in alteration of gut bacteria, that term. So the people who have this kind of thing, they are prone to get more COVID, severe COVID, basically. So now they are trying to collect the data, the stool sample from them, and then they are trying to like, the role of fecal transplant, fecal material for the management of COVID. So I never I never knew that it has a role in autism. So that is really interesting, I guess.
Okay, thank you for sharing that. I never thought that it's even related to COVID and it is complication, and it's interesting to hear that. Thank you, Somi.
I think there is a research paper regarding that. After this meeting, I will share that paper, which was sent by MSU Family Medicine faculty, I guess. So that was interesting. And this one, like your topic is, it's like, so how gut bacteria is important. That is like the whole thing. It can basically alter our bacteria in the gut, and it can give any disease. Like, as you mentioned, it can give cancer, inflammatory disease, or autoimmune disease. So even
obesity.
yeah, so it's like, it's very important. I think it's a very I would say, like, very growing field now, like I know, in perspective of like disease pathogenesis. And now they're trying to find out, like, especially the infectious disease scientist, that what's the role of like this fecal transplant in the COVID, like this pandemic.
Yeah.
So yeah, we'll see. But that, yeah, your your presentation was interesting, and you'd like to say if you have, I mean, probably in future, if you extend this research project, probably you will probably get some data, the real data, and I would like to see that, just because right now it is a literature review, right?
Yeah, right.
Okay. Mhm.
Thank you.
Thank you, Ryan, for the clear, concise, and the very nice presentation. Really enjoyed it. And as everyone said, this is really interesting topic that, as Sumi said, probably something is going to be growing in the future, looking into the effect of such environmental factors or other factors like this. So thank you for sharing.
You're welcome.
Thank you, Ryan. Very interesting topic. Very enjoyable. The way you presented is very good. I'm just curious to know, you mentioned that one of the topic that you reviewed was like trial in the animals as well. So how did they tested the clinical picture, whether it's behavior of the animals after, in one of your slides, if you remember?
Yeah. Yeah, they tested the behavior of the animals, and
okay, all right, thank you. And whether there is any check for like food intake preference, whether like these children's like are picky eaters, some sort of food intake or nothing?
no, there was no not significant things.
Uh-huh.
And what I found interesting is that they found some changes in their siblings, and I don't know why. Like the siblings were having some similarity in the gut microbiota with their siblings who are autistic when compared to control. So I don't know why the siblings have changes, but they did not develop autism. And yeah, that's what's interesting for me.
Yeah. Environmental maybe factors.
Yeah, maybe because they exposed to the same environment, they got that changes from the control, but these changes led to autism in the autistic children, not in their siblings. So I don't know, maybe some genetic factors at the end could be
that's what
because environmental factors itself was not enough to cause it in the siblings.
I agree. This is another area of research too. Thank you so much. I really love the way that you correlate it to Alzheimer's disease as well. So yeah, it's more convincing actually. Thank you so much. Sorry, Somi, go ahead.
No, I was just trying to say that I think, yeah, gene has a, because autism is a genetic disease too, right? So the siblings also shares the same gene and, also the same environment. So both of them are related to this gut bacteria as well as the same gene. At the same time, Alzheimer's, I think, also have a genetic correlation, right? So gene plays a vital role. That's all.
Any other comments or questions? I hope I am answering your questions well, but I'm trying to, because I haven't made any trial in this. So that's what I found by reading like 55 research in this topic. And then I came out with my literature review.
You're doing great. I think you did a great presentation. So any other questions, Ali or others? Any comments?
Hi, everybody. Thank you, Ryan. I have no question, but I just want to say thank you for the presentation and thank you for the talking about the autism and its causes. It's very interesting, and there's a big room for research there. Thank you very much, Ryan.
Thanks, Asa.
I definitely agree with all, and it's a really interesting area for research. And as you presented very well, the comparison between the two conditions, Alzheimer or in general dementia, and then the autism, I think it's elaborate. There is a role for some of the microbiome changes. So excellent work, and this a good area for research. Actually, here one of my colleagues is working on that subject, so they are doing some research, and I think they are planning to involve some functional MRI to see what changes with the brain there. So it can be extensively researched. So thank you. That's well done. Any other comments or questions, guys?
Thanks, Dr. Nader.
You're welcome. So, yeah, Ali, go ahead.
Yeah. First of all, I would like to thank Kayan for this interesting topic. Actually, I have a question for you, Dr. Nadir, for your friends' research. What are they looking for in functional MRI? I mean, in the gut or in the brain. They are looking for the research is in Alzheimer, right?
Yeah, so Alzheimer, as she mentioned, there are some changes, we call it plaques. The amyloid beta protein stuck to certain parts of the brain. So the functional MRI works as we'll see what area of the brain will consume energy or consume sugar, and it would light up the basic of that. So I'm not quite sure how they will do the study, but I was just talking about what the future here. So I know in a city nearby, it's called Grand Rapids, not far from Lansing. There are a couple of researchers there working on the microbiome and Alzheimer. And then Raza, who is my colleague, is talking to a different group about involving functional MRI. So it's kind of joining the two groups so that they can study it more. They did not start, as far as I know. Sometimes they need to get funding so they will talk about the process and applying for funding, and then they will get the research work rolling or going on. Excellent. Thanks for the question. Thank you so much, everyone. Thank you, Rayan. That was excellent summary and presentation of your work and important area and developing area. So we'll hear more in the future. Hopefully you will be involved in other research work as well. Last week or the week before, we had the grand rounds, and Sumi is gonna summarize or present something about what if you guys attended, that would be great. If not, maybe she will share some of the points, and feel free to add some of yours if you have been there. Thank you. Sumi?
Yeah, I'm going to share my screen.
Okay. Just a second. Okay, you can do that, right? Or go ahead. Yeah.
So as I was there, but it's as I don't have the slides for the specific case, so it was de-identified that, of course, and so I just try to connect that presentation and like overall intracranial hypertension. So like how management, diagnosis, and all that. So I'll little bit explain like what are the extra point the faculties and the resident and fellow they discuss. In the meantime, also I'll discuss the overall hypertension. I think that's okay.
That's good.
So everyone can see my screen.
Can you hit F5 or? No. Or go up to the, yeah. Oh. No, maybe on the screen, go slide show, just to present it as a slideshow instead of slides.
Yeah, 1 second. It's my PowerPoint is not responding.
It will take some time. That's okay.
Yeah.
So while she's uploading, I just want to share. I was in Boston and I spent some time there working at Mass General Hospital. It's a big hospital affiliated with Harvard. And the way they do their presentation, let's say for similar case in neurology, they go and sit down in a circle kind of seating, and then the presenter will be by the screen. The first row will be the attending, second row will be the staff, and then the resident, and then the students. So when they present, they will go around with some questions after the presentation to the floor. And they start with students, go to the residents, and then the attending physician, and then the specialist will try to answer the questions that they have. I think similar way we had it back home when we were doing our training, but in different places they may do the presentation differently. At Sparrow, they are free to sit wherever, and the questions will be raised by the attendee. So any students or resident or attending can raise the question. So here we go. Go ahead, Sumi, when you're ready.
Sure. So now everyone can see my screen?
Yes.
Okay. All right, so what is intracranial hypertension? So it is most commonly called basically pseudotumor cerebri. It is a disorder defined by clinical criteria that includes symptoms and signs of isolated produced by increased intracranial pressure. So what are the symptoms of intracranial pressure? That is headache, papilloedema, and vision loss, and also elevated intracranial pressure with normal cerebrospinal fluid composition, and no other cause of intracranial hypertension evident on neuroimaging or other evaluations, such as like pressure producing symptom, let's say like brain cancer or tumor, or some like cerebrovascular thrombosis, something like that. And it is very primarily affects women of childbearing age who are like mostly like overweight or obese. So the sign symptoms, this is the like definition, but what are the most common symptoms of IIH? Headache is the most common symptom. As we can see, it is like present literally 84 to 92% of the population. Transient visual obscuration, which is present like 72%, and intracranial noises like pulsatile tinnitus, like it's also 52 to 60%, photopsia, back pain, and like retrobulbar pain, and diplopia, and sustained visual loss. So as we can see, the headache is the most common symptoms, and like literally 92% of the population will have headache. So, and headache is a symptoms for so many diseases, and it's also causes like mostly like obese and childbearing age women. So it is like a very commonly like very common differential diagnosis is migraine, because this is like most commonly presented with female and childbearing age, and obese, and also headache. And also there are sometimes there is a triad of Cushing syndrome, like Cushing triad. Basically, what are those triad? Bradycardia, respiratory depression, and hypertension. So as we know what is a photophobia, but still I just put in case we need to just recapitulate our brain. So photophobia is the presence of perceived flashes of light in the field of vision. And what is double vision? Double vision is diplopia. I mean, a person to see like two images of a single object. Patients with IIH may report intermittent or continuous horizontal diplopia. And basically it can be unilateral or bilateral. And also this diplopia or double vision is a sign of sixth cranial nerve palsy. So if a patient comes with diplopia, I think it is a sign of intracranial pressure, ICP, and it can be isolated sixth cranial palsy as well. So what are the most common signs of IIH? So those are the most common signs are basically papilloedema, visual field loss, and sixth nerve palsy. And why this diplopia? Because it's the damage of the peripheral part of the abducent nerve will cause double vision, which is called diplopia, and due to unopposed muscle tone of medial rectus muscle. And how does that papilloedema looks like? So I took this is like basically there is a grade for papilloedema grading, like Fisher grade 1, 2, 3. So this is like grade 3. And this white arrow basically is showing like obscuration of a major vessel as it leaves the optic disc, like that arrow. So it's like it causes like optic disc hyperemia, edema, and finally it's obscure the major vessel. So if any patients comes with like, if we suspect intracranial hypertension, so before going to do any neuroimaging, I think the first thing we should do is physical examination. In physical examination, if we find anything, let's say like papilloedema or visual field loss or like sixth nerve palsy, sometimes like what happened, this based on this physical examination, we have to think like probably it is IIH, because neuro in the like very primitive stage, the neuroimaging even can show normal. So CT scan will not going to give us any answer until like, little bit of as advanced presentation. So the physical examination is very important for IIH diagnosis. So now I'm going to present like what are the diagnostic points. So it is diagnosis according to modified Dandy criteria, it's called, and each has to be each of the following should apply. So what are the symptoms and signs of increased intracranial pressure? So this is the same thing like headache, transient visual obscuration, pulse synchronous tinnitus, papilloedema, and visual loss. No other neurological abnormalities or impaired level of consciousness. Elevated intracranial pressure with normal CSF composition. A neuroimaging study that show no etiology of intracranial hypertension, means there is no like cancer or like space occupying lesion, something like that, and no other cause of intracranial hypertension apparent. So now the management. So this is like always a medical emergency, this intracranial hypertension, like any hypertensive encephalopathy or hypertensive urgency, this is a medical emergency. So urgent assessment and support of oxygenation, blood pressure, and end organ perfusion are particularly important in trauma, but basically it is applicable for all patients. And then in case of urgent situations, so life-saving measures may need to be instituted prior to more detailed workup, like imaging or ICP monitoring. That was basically I was trying to emphasize. In a patient who presents acutely with history or examination findings suggestive of elevated ICP. So like basically we have to emphasize if we suspect any patient ICP, we have to we have to emphasize on mostly history and examination finding. And many of these situations will rely upon clinical judgment, but the following combination of findings suggest the need for urgent intervention. So what are those following findings? A history that suggests elevated ICP like head trauma or sudden severe headache typical of like subarachnoid hemorrhage. Like people will say like, this is the worst headache in my life. And then an examination that suggests like elevated ICP, like unilateral or bilateral fixed dilated pupil, and decorticate or decerebrate posturing, bradycardia, hypertension, or respiratory depression. So this is the like Cushing triad again. And if a Glasgow Coma score is like less than or equal to 8, and potentially confounding reversible cause of depressed mental status, hypotension like systolic blood pressure less than 60, and hypoxemia like PaO2 less than 60 millimeter of mercury, and hypothermia or obvious intoxication are present. So in such patients, we may give osmotic diuretics used urgently because we have to resuscitate that patient. So in addition to standard resuscitation technique, we should do something like as soon as possible. So what are those measures? First is head elevation and then hyperventilation. Why hyperventilation? Because we want to keep the PCO2 of 26 to 30 millimeter of mercury and intravenous mannitol. So that's the osmotic diuretics. And then, this is the dose if we, in case we need, that's why I put. So I'm going to elaborate a little bit like what are the finding, I mean, why should we do like those things? Head elevation. So when we do the head, of course, it is due to gravitational change, we should do that. But head elevation above 30 degrees should be avoided in all cases. So this is a good point I found because we should not do more than 30 to 35, then it may cause some other problem. And in most patients with intracranial hypertension, head and trunk elevation up to 30 degrees is useful in helping to decrease ICP and providing a safe cerebral perfusion pressure of at least 70 millimeter or even 80 millimeter is maintained. So we have to make sure that by doing head elevation, we have to maintain the cerebral perfusion pressure is that much. And so that's why the CPP, the cerebral perfusion pressure, is the most important factor in assessment and monitoring when considering head elevation in patients with ICP. And so that's the point regarding head elevation. Then like hyperventilation. So how hyperventilation helps to reduce ICP. So by doing hyperventilation, we are inducing basically hypocapnia. So hypocapnia means less PCO2. As I mentioned that our goal is to keep the PCO2 is 26 to 30 millimeter of mercury. So it reduces the partial pressure of arterial carbon dioxide, which basically causes vasoconstriction in the cerebral resistance arterioles. And this constriction decreases the cerebral blood flow, which reduces cerebral blood volume and ultimately decrease ICP. So that's the pathogenesis, like how hyperventilation helps, decrease ICP. And what's the mannitol? Mannitol basically exerts its ICP lowering effect by two mechanisms. One is immediate effect because of like plasma expansion, and a slightly delayed effect related to its osmotic action. So, but mannitol is very, very, it's very toxic, and we have to make sure that it has to be, as I said, like there is a dose calculation is 1 to 1.5 gram per kg, and it has to be infused very slowly in 6 to 12 hours, very slowly. And mannitol is a very kidney toxic, so we have to monitor. To avoid toxicity, we have to monitor the serum osmolarity, and that should be below 320. That is our goal. And also serum osmolar gap. So I think each of we don't need to monitor both of them, but if we at least can monitor any of those, like serum osmolarity or serum osmolar gap. Osmolar gap should be less than 80 to 20, and osmolarity should be less than 320. So that is safe, kind of. As it is very kidney toxic, and the patient before giving to mannitol, we should always make sure we need to check the serum urea, BAN, and creatinine. And the patient who have a history of renal transplantation or any CKD history, we should not, we have to be very careful before put on mannitol. So these are the references, and I try to, summarize it, not too much. So I think Marwa was with me. So if Marwa can share a little bit more about the treatment option or something, that would be great. But that's.
Thank you so much. Go ahead, Marwa.
Thank you very much, Sumi, for the presentation. That was very nice. I actually attended the last part of the meeting. So I'm very thankful for that, the part you presented. So one of the I think two important things that I would like to mention here, that they mentioned in such case, in a patient presenting with acutely elevated intracranial pressure that's very high, and that puts the patient at risk of herniation, brain herniation, and death, of course. So the one thing to do is, like he mentioned specifically, to avoid certain IV fluids like lactated ringer. And the cause for that is that the ringer lactate or lactated ringer contains the sodium content is 130 millimole per 1 liter. That is equivalent to 270. The osmolality is 270, which is less than the normal. So it's like a sort of like a hypoosmolar solution. So you are doing just the opposite of what should be done. So that's like an important thing that he mentioned, to avoid such solution in that case, because the ringer lactate contains less sodium than the normal saline fluid. So, and it's like less than the normal for the actual person. So you're doing more harm than benefit in that case. Another thing that he mentioned, other than mannitol, is the use of 3% saline. Okay, so he mentioned one thing is that mannitol has one side effect that can happen, which is like it can redistribute back, like the mannitol causes actually works by like the fluid from inside the cells goes out when you give mannitol intravenously. So it will attract the fluid into the intravascular space rather than from this inside the cell. So that way it decreases the cerebral edema, but it has the ability to redistribute into the cells at some point. It's like minimal effect, but that can be can happen. So it will cause like a cerebral edema afterwards. So it's just like something that you should monitor if it happens. And that's why he offered also the option of using 3% saline, in which case that thing will not happen, or less likely to happen. So these are the two main points that I wanted to share. I hope they were helpful. And thank you.
Thank you, Marwa, as well. Thank you, Sumi. That's a great presentation, and you raised good points, Marwa. The third point I want to share is when you take the history, you're thinking about the differential diagnosis. When you do the exam, you limit your differential diagnosis, and then you think about the testing, what kind of testing, and how long it will take, how much it will take. And one of the tests that's a no situation in this patient is lumbar puncture. So you don't think about that. This is one of the tests that you want to avoid. You can go easily with the CT scan, you can go easily with other lab tests or whatever you want to do, but also think about no harm. Thank you, guys. Excellent presentation, excellent discussion. Any questions to either Marwa or Sumi from the group?
Okay, I'll start by saying thank you, Sumi, for the great presentation, and Marwa for the completion, and also Dr. Nader for the nice ending and what the importance of the history and avoiding LP. Sumi, yeah, I want to say first, you had the presentation very well, easy, the colors to the eyes, I enjoyed that, the transition, enjoyable topic, and the presentation itself. First, when you said diplopia, I was like, wait, do I have diplopia? I started looking there every side, but alhamdulillah, I don't have diplopia at the moment. So I don't have IC pseudocerebri. You mentioned the importance of imaging, that it's, in this case, it's not, and the importance of focusing on the physical examination, yeah. So that's the important point, as you said. And the Dandy criteria, thank you for explaining that point. And yeah, what I really liked more even is the pathophysiology, which you explained how the management is needed and the importance of it. That is, you're aiming to drop the blood flow towards the brain in different mechanisms. You explained the head elevation mechanism, which is against gravity, and the hyperventilation aiming to a specific number here. Yeah, as we can see in the figure, as you see, yeah, thank you for bringing that again. So the importance of it resulting in vasoconstriction, impairing the flow to the brain, dropping the blood pressure, and less risk of brain herniation, as Marwa said at the end, which is one of the consequences of this issue itself. Thank you for bringing mannitol into the equation here, explained its toxicity and the risk of the kidney being involved. And then again, Marwa at the end said it is also risky even after a couple of hours or beyond because of its risk of redistribution and resulting in brain herniation. So we need to be very careful about it. And also the importance of avoiding Ringer lactate because of its hypoosmolar solutions. Yeah, I enjoyed the presentation. Thank you. Thank you for bringing it back. And thank you, Dr. Nader, for the last points about the importance of the history for this situation. Thank you.
Thank you so much, Mulham, for
I would
your
like to
point. Go ahead.
bring one point, just like I remembered from the discussion, like especially the part mentioned about the kidney injury. Yes, this is something that really important and needs monitoring. But one thing he said, which is like, I would say like would be a point of like, I don't know, like not, maybe not everyone would agree on it. But what he said is, for God's sake, if the patient have this high intracranial pressure that can cause him to die, if you don't act, if you don't give him the right treatment, you can do renal transplantation, but you cannot do brain transplantation. So it's like it's like a point of controversy, definitely, but something that we really need to think about. Is like, yes, you need to weigh the risk and benefit in everything, but in this case, if the risk is to lose the patient completely, you might like just maybe settle with maybe a lesser risk that can be manageable at some point. This is just like something to just to keep in mind when treating someone who is like maybe at the verge of death. I'm not saying if like in any case openly, but yeah. So just I wanted to bring this up because this one was one of the things that one of his comments, the presenter's comment.
That's also an excellent point. And I'm gonna take you back to the geriatric situation where in medical school, we teach you about heart failure, how you manage that, or this patient with intracranial brain problem. Then you just focus on one problem. But as we get older, a couple of problems come together. Heart failure with kidney failure. What are you gonna do? How are you gonna manage both of them? Patients with GI bleeding and they have AFib, atrial fibrillation. So here comes the benefit and the risk. So the equation will be how far can you go managing one condition versus the other. In this condition, you think about the brain is vital compared to the kidney. The kidney, you can do hemodialysis, and as you said, you can do kidney transplant. But so you go for the step managing the brain first and then minimizing the risk as you go on. Excellent point. So thank you. Any other questions or comments?
Oh, sorry. Go ahead, Lubab.
Oh, thank you. Sorry, I'm not seeing. Thank you so much, Somi, Marwa, Mulham, and Dr. Nader, for sure, for the great presentation. Actually, for somebody like have been away from the clinical practice that long, I really appreciated it. I love the slide about the pathogenesis and how the reasoning behind the management. It's a great refresher. Thank you so much. I enjoyed it a lot. And please upload it to the system so we can go back to it again. Thank you so much.
No problem. Yeah, actually, for the case presentation, I was not from the beginning either because it's usually in the morning, so it's like I did not like I mean, I think I was also in the middle, but I tried kind of understand, like, the management part. I think I did not miss that much, but what I understood from their like grand rounds and like case presentation, they mostly, emphasize on management. Like, the resident and faculties, they explain like each and every methods, and and like why it is important, what is the adverse effect, and what are the things we need to like consider before giving anything. So that's why I try to emphasize, I mean, explain that, because when I was there, they are like talking about head elevation, hyperventilation, and intravenous mannitol, these three things. They're literally like, explaining like what is the why we are doing head elevation, what's the importance of doing hyperventilation, and how does it work. So the residents, like the faculties, are asking those questions to residents and fellows. So I think that is a most important part also as we are preparing for residency. So, and also like I mean, many of us like recently took step 3, and like some of us little bit like far away. So I think that's it is like very interesting, and like we should keep doing that, like at least one or two cases, like every week or something like that, that will refresh our memory, especially the management part. And that's why I want to I would like to join those grand rounds, because by that way I know, like what are the things we need to emphasize on, and what are the things they discuss in, like in patient perspective. Because when we took USMLE, that is a different thing, I guess, because exam curriculum is different, and I mean the content is same, I would say, but here we are more emphasizing on management, I guess, than the diagnosis and other stuff.
I can't agree more. Yeah, that's absolutely true.
Mm-hmm.
Thank you so much. As Dr. Nadir said, like they taught us something in the medical school, and now we are facing something different. Yeah, weighing the benefit and the risks. So exactly. Thank you.
Mm-hmm.
Excellent, excellent. And I just also want to share, I did 1 year in New Jersey and the other 2 years here in Michigan. So there are comparison between how attending teach students or residents or fellows. There's those group who are like from different schools where they teach you through questioning, and don't be intimidated. They may be tough on you, question you very, very harsh. And the idea is not to humiliate you or put you down. The idea is to think about what you are saying, what you are doing to the patient, how you are learning. As Sumi mentioned, these are the steps. They can put it in a bullet point, they can put it in a protocol, and you cannot be like a machine. You follow what the steps. So patient with this, you do this, and it's done. But not this is not the way they want you to function or to think, because they want you to learn the basics, the mechanism, and understand what the management, why you are doing it. And also it further the step, what we are doing now is the research. Sometimes you do things and maybe you think about it, maybe this is not the best, maybe it was best at that time, 1980, but here now we are doing, or we have something different available. So maybe we think about the problem differently or some situation. So when they ask you these questions, don't be afraid, don't be shy. If you don't know, just pass it or say, I don't know, I'm gonna figure it out, I'm gonna answer this question later. And then there are some attendings who just want to get you in the rolling. They don't ask you too much. So don't feel good about that as well. So you try your best to learn, explain to yourself and others. So it's a learning process when you're doing your residency, if you have the time to teach yourself and others. Thank you. Thank you so much, everyone. Any other comments? Please feel free.
Thank you very much, Sumi and Marwa. And as Lubaba said, this is like bringing memories back from the days we were practicing medicine. and that was very useful. For myself, I was working in an intensive care unit for almost 2 years, and we used the exact measures for any patient with increased intracranial pressure, intubate, hyperventilate, and using of mannitol is like inevitable. Like we have no, with all the discoveries in medicine, there is a little alternative to mannitol. And as everybody said, the risk and the benefits, we have to outweigh the benefits of the risk. And I remember that I was interested to know that why patients recovering from the like increased intracranial pressure and using of ventilator, and they're regaining their conscious level and they're slowly recovery. A lot of them develop diabetes insipidus, even without the use of mannitol. So that's that we see that a lot in a lot of patients. And but thank you very much for raising up interesting topic, and thank you everybody.
Thank you, Azza, for your comments and sharing your experience. Thanks. Any other comments?
Yes, can you hear me?
Yes.
Yes, I would like to thank both Sumi and Maura for the great presentation. It has been a great reminder to the clinical presentation of intracranial hypertension. There was a point that I want to ask about. I think Marwa mentioned that elevating the head of the bed to a certain angle is contraindicated. What was that exactly?
Somi actually mentioned this part in the presentation. I believe she said not to go beyond 30 to 35 degrees, the head elevation. Like you don't want to, like, I would say openly elevate, just do head elevation. There's like up to 30 to 35 degrees of head elevation that's reasonable and suitable for that case. If Sumi wants to add anything.
Okay, yes, great. So elevating the head of the bed is a management plan or one of the things we can do to decrease the trachea pressure. But it's new information that I did not know that there's a certain angle that you should not exceed. So thank you for that.
You are muted, Sumi. Sumi.
Sorry, today I'm using my daughter's computer, so I'm not very familiar with that. So, all right. Khalid, what I'm trying to tell you is that head should not be more than like, more than 30 degrees, because basically our goal is like decrease the ICP, right? So if we go beyond like 30 degrees, so our another goal is to cerebral perfusion pressure to keep it like 70 to 80. So if we let's say if we elevate our head like more than like 50 degree or something, so the cerebral perfusion pressure will be elevated too. So which like more than 80. So we don't want that to happen. So to keep like CPP, so how do we measure is my head elevation is correct or not? So that's the CPP is the most important indicator that head elevation in patients with ICP, that we are doing it correctly. So that's the whole idea. Hope it clarifies your point.
Yes, that is clear. Thank you.
Mm-hmm.
Thank you, everyone. And a short tip, if you want to unmute yourself for a brief period, you just hit the space bar down and then it will unmute you. And when you release that, you will be able to be muted again. So it's kind of a quick step to do that instead of searching for the point or the. Any other questions?
Good one.
Thanks. Any other questions or comments?
Yeah. Can you hear me? Go on, Marwa.
No, go ahead.
Okay, Ali, go ahead.
Yeah. Can you hear me now?
Yes.
Hi.
I see you are testing the space bar, I think. No, I'm just kidding. Go ahead, Ali.
So, yes.
What's your question again? Sorry, can you repeat?
Um, can you hear me now?
Yes.
Okay. So, first of all, I would like to thank both Sumi and Marwa. I do have a question for Marwa. So you mentioned ringer lactate, so not to increase sodium concentration. Correct? Right?
Not really. So basically,
my question is,
okay.
Uh-huh.
I'm listening.
Okay. So my question is, okay, what about hypertonic saline? Did I miss something, or what was that? So I think hypertonic saline contains more sodium, right?
Yes. The thing is, like the hypertonic saline works at the same concept as mannitol, as something that is hyperosmolar. Okay, so you should avoid. The point is to avoid things that has low osmolality or osmolarity, whatever, like that will cause to decrease the osmolality of the body. Okay, this is the aim. So he mentioned like the specifically, for example, the 1 liter of ringer lactate contains 130 millimole.
We lost you, Marwa. Unmute yourself again. Sorry, we lost your voice.
Okay, can you hear me now? Okay, all right. So the point is the lactated ringer contains 130 millimole of sodium per liter, which is less than the normal for the body, which is 135 to 145. And actually, like this is the rationale behind avoiding it, as he mentioned. It can be one of the harmful solutions to use in such situations. This is like what this was his point. Okay, so because the overall osmolarity of the lactated ringer is around 270, which is the low normal or lower than the normal for the body. Okay, so it's like as if you like do he mentioned it, so as people should avoid it, not to do harm in a person. Like when you consider fluids that you can give to this person, avoid ringer lactate. This is the point behind what I said. The other thing is the 3% saline actually contains as I believe 254 254, I think, or if someone can correct me, millimole per liter, okay, of sodium. And actually it is gonna like the osmolarity is on the high level, not 270. It's much higher. I believe 300 or so. So it can act in the same manner as mannitol, as a hyperosmolar solution that will drag the fluid out of the cells of the brain. Okay, so it can cause like diuresis or something like this to just shift the fluid back from the brain out of there. So this is like what I understood from the rationale of using it. And this, like, these are the points. I hope they are clear for you. If anything not clear, you can say, I can maybe try to explain more, or someone can help.
Yeah, thank you. I just thought finger like it has more sodium, not less. That's why it
No.
confused me. Thank you.
You're welcome. And just one final thing that I want to share, like the idiopathic intracranial hypertension used to be called benign intracranial hypertension in the past. And I remember the comment of one of our professors in medical school saying that this is like a great misnomer, because actually the long term, like if the chronic raised intracranial intracranial pressure and the back pressure or at the back of the eye and the optic disc will eventually lead in many patients into blindness. Okay, so this is one of the things that, like, this disease is very important to manage because of the risk on the long term if the raised intracranial pressure not treated successfully on time.
Yeah, I think Marwa is right. And also when I was reading for this, when I was preparing the slide, I mean, different journals I was like referring to, and that, that is very important to know because it is misdiagnosed as a migraine. Like, I think in my lecture, I mentioned that because it is like childbearing age and like women and obese. And then, all the symptoms like photophobia, and like severe headache. It is like, I mean, not everybody comes with the severe headache. It can be like very mild headache. So headache is very non-specific. So I think like headache and retroorbital pain and like kind of like ICP elevated symptom, let's say nausea, vomiting, and childbearing age and women. So all, it is a very good combination of migraine as well. So it is like very especially like I mean anywhere, like in a rural place also it can be mistaken with migraine. And so in the long run, what happened, like there are something like called acute ICP and then chronic ICP. So probably it's mildly elevated, but it is a chronic time, let's say 2 years, so it is not managed properly. So long time chronically, in ICP elevated, it like again same thing, like it's literally cause like papilloedema, and like it is the most like very common cause of blindness as well. So that is why the history and physical examination is very important when a childbearing age woman obese comes with like this kind of like headache and migraine kind of syndrome. It is very important to exclude ICP because like there was a case report I saw that it was taken care of a rural patient, and then she was like basically Imitrex she was taking for a long time because she was mistreated as migraine. And after 2.5 years later, she comes with literally one eye, like like long-term papilloedema, optic disc swelling and all that. And then she was referred to ophthalmologist, and then ophthalmologist found out that basically she has ICP, not migraine, but she was mistakenly treated for migraine for 2.5 years. And I think like, she was almost close to blindness. Thank you.
Great point, Tommy. Thank you so much. You made me worried. I have all of these symptoms. Thank you.
In the past, we used to call this medical student syndrome. Now we'll call it fellow syndrome.
I agree. I had it since medical school.
No, this is very common, Lubaba. I think, I mean, here, like, we are like 1, 2, 3, 4, 5 women, we are here. I think all girls have this kind of symptom. No worries. You're not alone, okay? We are with you.
Thank you.
Any other questions or comments? Thank you all for all your sharing and your points, your questions, and thank you for presentation, Sumi and Ryan and Marwa. Let's switch to a different section. Any questions before we jump into maybe the research part, and then anyone with news about interviews, anything to share?
I had an interview yesterday. All I can say it went well, and I cannot overemphasize the importance of just like to practice on a daily basis. I believe this was the thing that helped me the most this time. In the previous ones, I wasn't practicing on a regular basis, but for this one, I was like just on a daily basis, not just specifically for this one, just overall. And I believe that made me like less stressed and maybe more focused and able to um, answer in a hopefully good way. Um, like just one question, like nothing like most of the questions are like the similar, like regular ones. Just one question that I believe many might have been asked the same thing, like mention, but it was specific in a way, like mention a moment um, when you felt most proud of, like of something that you achieved or something like this throughout your career. So this just was one thing that I was asked, but overall the rest of the questions were the regular known type of questions.
All right, so I had an interview last week. So it's a university program. So of course, like they are talking about research and all that. So I think, yeah, thank you, Dr. Nadir, because nowadays, like, I realized that it's better to put the camera on, and that helped a lot, because initially it was very hard for me to, because when it was a panel interview, literally I had to concentrate on 3 people and on their side. So one person is finishing the question, another one is like going through this. So I think this is very important. So that's why today I decided like I'll be turning on my camera for the whole time, no matter what. So, and also like it's it is like helpful, and it is anxiety too. So, and one thing I wanted to say, like, the interview questions are like literally same as usual, but one question, like, one or two questions I was thinking like it's very like, like they ask like, how do you consider someone's mistakes? Like if someone, your colleague or let's say you see like, a faculty's mistake or someone's mistake, how do you consider that? So what is your opinion about it? So, I said like nobody's 100% perfect. All we do mistakes every time. But if a person can, we should learn from our mistakes and move forward. We should not consistently do the same mistakes. That's all I can say. And another interesting question was, associate program director, like he literally like I feel like he knows my CV better than me. So so like I was really impressed, like every single point he was emphasizing. And then he was asking like, as you are doing a master's, you are enrolled in a master's program, you are working at UFM as a researcher, and then you are doing a geriatric fellowship, you have a family, so how do you manage your time? And how do you manage everything? So then I said, if a person is dedicated for and hardworking, I think that's 2 words is more important. If anybody is dedicated and hardworking, anyone can achieve anything. And of course, like organization skills is very important in order to do multiple things at the same time. And then he goes like let's say at this point you are a you are a researcher, you are a student, you are a mother. So what do you think, like what is the most hardworking job out of this, and what is the most satisfying job out of these things. So I mentioned that, I mean, being a mother is the most hardworking job, I felt. There is no vacation. It's a 24/7 job. And, but being a physician and treating someone is a more satisfying job, because if you cure someone, no money can bring, or nothing can bring your like satisfaction is the most important thing being a physician. So I point out those points. And yeah, I think, like, here's, I mean, I don't know, like, everybody shows like they're very happy, or so that is a common, I think they are common attitude. So yeah, like, rest of the questions are as usual.
Excellent. Thank you both, Marwa and Sumi.
Thank you, Somi and Marwa. Thank you so much for sharing your experience. Just please add those questions to the document Marwa shared with us. Thank you and good luck.
Thank you, Lubaba. Definitely, I will do that.
Marwa, the interview questions are in the app, or you shared in the Google Doc, right?
Yeah, as a Google document. I shared not the common known ones, but the ones that are, I would say, maybe less common, and what I heard some people were asked. I'm gonna add even more to them, because like from the some of the friends of mine that I practice with, they were asked like different questions, like other than the one that I encountered before. So yeah.
If you don't mind, Marwa, can you send me a link also? I will put it in the app. Thanks.
Definitely. Okay.
Thank you, Marwa and Sumi, for mentioning about your interviews. And it's great to hear that it went well. And I'll share my previous experience of the last week. I had 2 interviews. One was surprising. I had just about less than 24 hours to confirm I had the interview. Alhamdulillah, hopefully it went well. I'm not sure. But I'll explain what happened there. But before that, I want to say that the importance of letter of interest. I got those 2 interviews based on letter of interest. The first one, I sent it at the 1st of December. I got it on the same day after exactly 4 hours from sending the letter of interest. So I think, yeah, they'll look into our messages. It depends on luck and the timing. If you send your, let's say the first thing, let's say, sorry, I didn't open my camera. Yeah, Assalamu alaikum. So yeah, it's from 6 to 8 a.m. That's when I usually send. That's the best timing, I think. If you're sending towards the program coordinator, they're gonna see it by 8, 9 a.m. usually. So that's if they open it. Now, I had that opportunity the first time. I sent to about 20 programs, only 1 responded, and 1 waitlisted me, still waiting for them. Maybe it will change, maybe not. But the second time around, I sent about 1 week ago, I got the second one. So anyways, I wanna say, just try to make sure to send, give about 2 weeks period and send again. And inshallah it will work well. And today I will send a copy of my what I usually send to the programs, and please use that or apply what you usually prefer based on what I have. I think it's working. I applied it twice and I had 2 interviews. So please use that, and inshallah it will work. Also try to focus on the programs that you feel you fit the criteria. I sent to university programs because I noticed that my CV is more, the interest of programs are more based on universities and not community programs, because I didn't get invited from any community. It's always universities or affiliated universities. So I focus on that. So maybe they feel that my CV is more on teaching, research, and such things. So if you feel you're having more clinical experience than publications and teaching experience, focus on the community program, because there is still some amounts, and there is cancellations expected in the next couple of days. That's something I wanted to share first. And yeah, the second point is there's no updates on the research project yet. Inshallah, next week there will be some new updates. And yeah, we will start the project, which is the commonest risk factors of COVID in the geriatric population this week. Ali mentioned his interest, and please, anyone who's interested, let me know. And I will send also Dr. Nader the text again later on. If it's possible, please send me, or let's discuss about the results if it's ready, so I can be involved in the process. So we can finish it by this week, inshallah, the project or the poster presentation. And that's the part about research. And yeah, so there's a couple of things I noticed that sometimes they would cross the line in terms of based on the NRMP rules. I think they crossed it twice during my interviews. Once is in the last interview, which they said, how many interviews do you have? I noticed they were interested, so they went to that area. They usually shouldn't go there. That's not something, some would say, don't feel comfortable responding to that question. I didn't say that. I said 15 interviews. I don't have that number of interviews, but I said that. Astaghfirullah. Anyways, I said that because I knew that they were interested in me, and I let them know that I'm a competitive applicant. And they said it from the start, you are a competitive applicant. So I gave them that number. So hopefully it goes well. But I didn't stop there. I said, even though I had that number of interviews, you are my best program because you fulfill my criteria and the area is what I'm looking for. And that's my dream goal. So, and they say, you fit us very well. And we hope you have future in our program. But then again, sometimes programs just speak and based on different things, because the ranking process is a different thing. So hopefully it goes well in that part, but let's see later on. Then, yeah, the importance of questions. I think it's very important. Right now, I started to focus on it more than before. Initially, I was just preparing generic questions. I did change the template of how I formulate the questions. First, I have now a story. I didn't mention the last time I started to change. Yeah, I think it's working in terms of first mentioning some positive thing about the program director or their way of teaching or what they have changed in terms of the program, and then asking the question. So it's a bit longer, but they would love such a thing. And you would respond for about 2 or 3 minutes in every single question. So that's, I think it's important. And sometimes programs provide more time for the questions. Yeah, the joke is very risky, but if you're able to say a joke, it changes everything. I tried it in 3 interviews now. It's working perfectly. It changes the mood from being formal into informal. So yeah, try it if you can. Yeah. Then ask about vaccine or their opinion of vaccine if you feel comfortable. It's a bit risky. I did ask that. And I noticed that at a certain period there was like, okay, it seems like I'm afraid of the vaccine. So I needed a comeback. So I did a comeback at the end when I was asked, or actually there was a question here. Yeah, the question was, where do you read? If you have a clinical case you wanted to read or something to want to investigate the clinical point. So I said I would go for UpToDate, but then again, I would go for JAMA, Journal of American Medical Association. That's something I enjoy reading. It keeps me updated based on the research. It's just like the COVID, and I use the COVID topics to understand and gain knowledge. At the same time, use it for my inner circle to explain the different variations and all that. So I turned it around because I felt that they had a misinterpretation that I asked about the opinion of vaccine, that I'm afraid of it. So I use another question to let them know that, no, I know what it is, and I'm helping my inner circle, and I'm trying to apply it on a bigger circle in the future. So they said, I like your attitude. So alhamdulillah, it went in that area. I was able to do a comeback by the end. Another question I was asked, which is, why did you apply now after 4 years from graduation? Because we usually have applicants who are usually the first or second year. So yeah, and I've seen, mashallah, they're very young and American graduates. But I was able to compete and be part of that university. So they were like, why you're here today? I felt a bit, they're placing me on the wall there or so on. But I mentioned at first I did this, and there's translation. They said, oh, the amount of experience you have is really big in comparison to someone who's just graduated 4 years. Like, yeah, be careful. Anyway, so if you found, this is a third question, which is, if you found a patient on a floor, either. And before that, they gave me first thing they said, this is a very tough question, Mulham. I was like, okay. If you found a patient on the floor, either drunk or cocaine user, and he's combative or non-compliant, what will you do? So I took a pause to analyze what is the purpose of the question. And from the first thing I noticed that what they're looking for is being practicing open communication. So I knew that I needed to say it, but in the right context. First, I said, I will sit on the floor with the patient. They were surprised. Why sit on the floor? I said, because I want to make sure they understand I'm respectful to them. And then I went towards, I'll speak to the patient, listen them out, understand their concern, because if they are not compliant, there's a reason. And I need to practice open communication. So by that, they were like, okay, they started writing down, because everything I was saying, they keep on typing. This program, they were typing on the computer in comparison to writing on a paper. And yeah, that was the part I explained. I think I went a bit more than that. I said other points based on this specific question, but it covered the main basis here, which is practice open communication. And I gave an example that I had dealt with this situation before multiple times in my country when I had clinical training. And this is very common, and it's a most common situation here of non-compliance is misinformation, or it might be an issue with a nurse or a physician. And if you just practice open communication, it solves everything within a couple of minutes. And that's why I always practice open communication on a daily basis. And they were smiling and they kept on writing. So I think that's what they're looking for. And I've emphasized on it multiple times. And yeah, I always run to my experiences whenever I feel myself in a situation like a clinical scenario or a behavior question. I return back to the experiences I had before. Then they asked me, yeah, so this is something that is, I think it's important to know that the vaccine, the Pfizer, is resulting in allergic reactions. It's resulting in anaphylaxis. So this is something that's happening. And one of the program directors said, Mulham, yesterday we had multiple cases. Multiple of the residents had issues, didn't know what to do in terms of managing anaphylactic shock. I want to know from you, how will you deal with a patient with an anaphylactic shock? So I was like, I will do this. Okay, that's the first line. What do you do next? Second line, I said it. What if it didn't work? What do you do? I mentioned the three main approach of management for anaphylactic shock, which is epinephrine and corticosteroids and antihistamines. She was like, whoa, that's okay. All right. Okay, that's well, Mulham. I was surprised. This is not an interesting or something new. We all know that. This is a simple question. Maybe during an interview, it's not expected, but I think just being relaxed, we can solve such things. And why should you ask about anaphylaxis? Because something had happened before, one day before that. It's interesting in her mind. She's comparing me to the residents to see if I'm well in terms of knowledge and all that. So yeah, anyway, then I want to share it. One of those programs had the traditional schedule. What is that? So there is traditional and X plus Y, or X plus Y schedule. So the X plus Y schedule is the most programs have it. And it is usually say 4+1, 5+1, 3+1, and so on. And this mainly aims to show that the importance of inward and outward, or the inpatient and ambulatory medicine. That's and mainly aims to make us able to not have a mix between inpatient, outpatient, which is a burden. And that's what was the traditional or the old system. Most programs stop that. And when you have that, you know that you will be working more hours, probably up to 7 or 7 to 9 p.m. That's one of the programs I have noticed had that traditional system, which is a mix between both. And yeah, X is for example, it means inward, and Y, for example, it's the clinic or the outpatient. So you have 3+1, 4+1, which means after 4 weeks of working in the inward, you're going to be a bit relaxed by the clinic. That's, I think, the basis behind it. Yeah, and most programs will say we are proud we are having this process, and probably have changed 1 or 2 years or maybe 3 years ago. Then, yeah, I think I went through that part. Okay, those are the questions I think I was asked. I will share it also with the same file that Marwa mentioned. Inshallah, 3 questions that are new here. Yeah, also the thank you letter. I think any one of us who had an interview, you need to send a thank you letter immediately within 48 hours. Just it's a courtesy, it doesn't change much, I think. But if they respond as good, maybe they don't, usually they don't respond usually. But sending a thank you for inviting me and something like that, or something that we recall is good. And holiday is coming. I think it's next week, the Christmas. So we can send something that we're really gonna rank you high, and we're gonna rank you high based on 1, 2, 3, 4 points. That's if you feel comfortable using that. I did already. I did send my letters to all the programs. So I'm just letting everyone know here, if you feel comfortable, we can do that. Send them either a letter or an email. That's something that shows that really genuinely care about them, especially during this year, because we haven't met them in person. It is not like now. So we need to show more care about the program. The one who shows more, that's the more one. If we did well in the interview, followed by that approach, we will be, inshallah, will be ranked higher by that approach. So yeah, that's the point. Then, yeah, I think I covered the most important things here. And as Marwa said, practice a lot. That lowers the stress, definitely. I started practicing more after my third interview. It's definitely important. It lowers the stress, and yeah, having a framework, not just looking at the paper as it is, having a framework, for example, the first point, second point, and the third point. My approach is having an interesting start, and content-wise, it's almost the same based on a story. And the end, it's usually something big. I'll give you an example. So, excuse me. For the last interview, which is yesterday, I had a situation where the interviewer came a bit late. I should have been having a 15-minute interview. She came very late, 5 minutes. She said, we will have 5 minutes and we'll get out. So I felt she was already tired. She is like, all right, let's do it. 5 minutes and that's it. You'll get out of the room. So I knew I have 5 minutes to change everything. Maybe I might have some time based on the interaction. So we started talking. She said, speak about anything, internal medicine, what you like and all that. So I made a mix between why I'm interested in internal medicine and my areas of strengths in terms of being a hard worker and the teaching part, that something that I'm very proud of. So I explained that with passion and the hand gestures and all that. And I ended by saying a phrase which made her pausing for about 10 seconds. She was in freeze mode. At first I thought maybe it's the internet, but then again, no, it wasn't the internet. She was surprised. The quote was, I said at the end, which is, this field is fascinating and captivating and filled with unique, vibrant experiences. So she'll look at me like 10 seconds of pause. And then she asked me when I went out of the room, she said, get me Mulham back in the room. I want to speak with him more. So alhamdulillah, she changed her mind in terms of giving me 5 minutes. And we spoke for about over 40 minutes after that, because I kept getting out of the room, get me Mulham back, because there's a time limit in every room. So we spoke about literally everything. Every single question that there's there, we had a discussion on, starting from tell me about yourself, why you're interested in internal medicine, why did you apply to our program, what is your areas of strengths, hobbies outside. By the end, she was like, Mulham, I don't know why, but I like your attitude and your approach. I think it's all based on the framework she liked, because I'm placing every answer based on a framework. I think that's the goal. And at the same time, I'm using my hand. So yeah, and I did say it. I said, when I do teach, I prefer to use my hand. I was very careful there. Why I'm saying it? Because I know the criteria. We discussed this. The criteria is based on interpersonal skills, using hand gestures, and showing commitment to the field. I made sure every single point there, I was clicking on it while answering my answers. So she said, you're someone who's very engaging. I like that, your approach in life. And so yeah, alhamdulillah. I think it's important to know the criteria while you respond to the questions. That's very crucial. That's the questions I think I was asked. Yeah, she asked me about, do you have research projects? I respond to all that with different projects I dealt with. And I think the main parts, yeah, interesting case. And I'll be sharing this question. I think this list is very good, which is about 30 questions that I have almost, this are the questions I'm practicing on a daily basis. And those questions, I think I'm having it on every interview, especially the last 3 interviews. I'll share this, just the questions real quick, but I will send it inshallah later on. because if anyone is seeing this video later on, maybe they can understand or know those questions immediately. So first, I was asked, tell me about yourself. Why did you choose this field or internal medicine? Why did you apply to our program? What are you going to add to our program? Or which is what are your areas of strengths? What is your weakness? And 1 or 3 words to describe yourself. Hobbies outside of medicine. Where do you see yourself in the next 5 years? Research projects. What are you looking for in a program? Then there is conflict resolution. Give me a scenario where you were in a conflict and resolved it. You worked under pressure. That's one of the common questions also. A senior gets upset from you. Or tell me a scenario where a senior gets upset from you and how you dealt with it. Who do you consider as a difficult team member and how you deal with a difficult team member? I was asked this question yesterday. What is your biggest achievement? I think Mara even mentioned it, but in a different way. Feedback that improved you also is the second question. An interesting case. What is your biggest fear in medicine? Relative of a patient upset from your management. That was one of the questions. Challenges expected in residency. Challenges or difficult patient that you dealt with. Mistake or compromising a patient's life. And what is your leadership role? And once you had to do a quick decision making. Challenges during medical school and how you overcome those challenges. What is your plan after residency? I think those are the questions which covers, and those are the common questions. And the last one, I think Dalia mentioned it last week, which is negative feedback. I wasn't asked this question, but yeah, that's the only one I added here. And yeah, I think that covers everything. I hope that was helpful. And yeah, I hope everyone good luck. Thank you.
Thank you so much, Mulham, and thanks for sharing and making it easy as far as tips wise and organizing the answers. And if you can share these questions as a file also, that would be great. Any other comments? Or
thank you, Mulham. Sorry. Go.
All right. Well, first of all, thank you, Marwa, Sumi, and Ryan for your the presentation today was very helpful. I wanted to share my experience, but I think you wanted to say something first. So Marwa, you can jump in and I will talk later, okay?
Well, I just wanted to thank Mulham, honestly, because these were very useful and really important tips and very thorough point that he mentioned. So just thank you so much and wish you all the best.
You're welcome.
All right, so I had two interviews, one community program and other is university. So for the community program, I had 3 interviewers. Everyone was 20 minutes each. And they were asking mainly questions about they work for the underserved, so they were asking about the community services that I had during medical school and stuff like this. And they asked a question that what motivates you? 3 things that motivates you. That was a very difficult question for me because I wasn't ready for that. What else? They asked me interesting case during medical school or afterward, and conflict with this senior or anyone. And they asked about my experience during, for example, like my observership and things like that. But they're more emphasizing on working for the underserved. So, like again, my volunteering and community services. They asked about what else? Error. So medical error and leadership. Another good, tell me about yourself, of course, and things that you're going to add to our program. Oh, one question the PD asked me that, tell me a weakness, and please don't tell me that I'm perfectionist or I'm just too good or too nice, because those are not weaknesses. So tell me a good weakness. And then I told him. And what else? Strength, of course. And then, yes, the error, leadership. Sorry, I'm writing this down, so I'm trying to remember. Why this program, and teaching philosophy. So what's your teaching philosophy or your teaching style? So those are the questions. It went good, I will say, the last one especially. However, the community program was a disaster. But alhamdulillah, it went fine, I guess. So that's all.
Thank you so much. Really, we appreciate, and thanks for sharing.
Yes, thank you,
everyone. Go ahead.
Yeah. Thank you, Dalia. Thank you, Mulham and Marwa. Thank you, everybody who shared their experience. And Sumi, of course, congratulations. And best of luck to you all. I have two questions. One is for Mulham about your letter of interest. Did you make it a generic letter or did you personalize it to the specific program? And the second thing is not a question. It's just I'm sure everybody's seen the recent letter of the AMC regarding this season's interview maldistribution or so. Just would like to reflect on everybody's opinion. And I know that a couple of us applying this season, not getting interviews so far. And hopefully, hoping that things will turn around and we will get some. But I just need to know your reflections about this letter. And that's it. Hopefully I will not mess with the agenda of this meeting, but be like, I wanted to hear about you what you think, guys. Thank you.
Okay, thank you, Azza, for the question. I'll respond to the first, and I'll just point to the comment on the AMC message, and I'll leave my friends here to comment on it also. So the first, yeah, I tried to make it more personalized, but it's more, frankly, it's a bit generic. I have a certain form for it. I'd send it to almost all the program the same, but the second portion, somewhere in the between, before the my CV, I mentioned something about the program. Either I would have seen the program director somewhere, either he could have participated in somewhere in terms of AMA meeting, and then I would watch that, and then I would make something about it, that I was interested in his approach of teaching and his style, or something unique about the program in terms of innovative approach, different from other programs, something they're proud of. So I'm always looking towards the program side and analyzing what is unique and differs from one to another. And so I'm using that and placing it there and send it to the program coordinator. So the program coordinator will analyze and know that, whoa, I actually know them based on 2 sentences or 3 sentences. And yeah, if they look at it, and if that requires luck for them to open because they're very busy. So inshallah, they would see our messages, everyone's messages. And but yeah, it's a bit generic, but they won't feel it's generic because of how it's prepared. They are not familiar to it. It's a bit in bullet points. I try to make it very artistic so that they can, when they see it, they will be compelled to complete the message and provide an interview if they have a position or spot, or at least wait list. That's the aim of the message itself. And I will be sharing a copy of it to the group, inshallah, today, with these messages. Second thing, the AMC, yeah. So the AMC message, they had about, I think, 3 sections or 2 sections of it in the letter. The first portion was based on mentioning the issue that is happening this year, which is based on most interviews are provided for the high tier applicants, while the remaining middle tiers are not having any. Usually in every year, the higher tier and middle tier applicants, they have good number of interviews, and we are included in the middle tiers, most of us, and the high tiers are the American graduates. So they're looking here for, also some of the American graduates are included in the middle tier. So they are afraid mostly for the American graduates, and some of us, because we also make part in this organization, we're contributing. So that's why they're very afraid in terms of that part, because it's very clear that the spots are filled by only, or one applicant has about 30 or 40 interviews. That's an issue. Last year, it's one applicant has 15 to 20 in terms of the high tier. So this results in terms of no one is having enough to get ranked high. So they made an opinion by the end saying, for every applicant who has more, try to share if you have enough, please send or reject or cancel your interviews. At the same time, they sent to the program director saying, if you, no, they said actually try to have a solution for that by saying rank more than usual. For instance, some programs, they would usually rank about, if they have 300 interviews, they would rank 150 or 200. Now they need to rank more instead of every year, because most of applicants who are unique or they think they are best, they are already having other sites or other programs. So maybe they would have ranking for 250 or 300. Now, is that enough? Based on the message itself, it seems that they're saying to other programs, try to have more spots of interviews. Now, we need to be hopeful. Inshallah, there will be more based on this message. Inshallah, they will have more spots for interviews next month. But then again, the letter of interest should be done, I think this week. It's better than the week after, because everyone will start sending letters of interest after, that is during January. Yeah, that's just my opinion. And inshallah, there'll be more spots and all of us will get the interviews this week and next couple of weeks, inshallah. And good luck.
Thank you so much, Mulham, again. Anyone else? Go ahead.
Thank you, Mulham, for your valuable tips and discussion. I forgot to mention one thing actually, because I think the program director or associate director, I cannot remember, but the question was about COVID vaccine. So he was asking if the COVID vaccine is available to me, or there is an opportunity that I can take it tomorrow, will I take it? And when I expressed my interest or whatever, then he said do you think it is safe for you? You are in a childbearing age, and do you have do you know any data regarding childbearing age and the COVID vaccine effect? So I think he wants to know that, before taking the vaccine or something, how much I know about vaccine safety and efficacy. So then I mentioned that as the vaccine is very new and it is not FDA approved. I mean, FDA approved in emergency situation, but it is not mandatory. As from work also, I'm not a frontline worker. I'm just work for the research. So my priority is category C. I mean, if they categorize A, B, C, I'll be considered in a category C. So if they do not, if it is not mandatory, flu vaccine is mandatory for us. So if COVID is not mandatory, I would still wait to see the data for childbearing age, as that there is no data available at this time point. And if the post vaccine surveillance data is good, I probably, and as I'm not a risk factor, I do not consider myself as a very high risk factor, no diabetes, hypertension or anything. So, and also I'm working from home, so I'm not considered at this time point. But of course, I'm eager to see the efficacy and safety in perspective of childbearing age, and also the other side effects such as anaphylaxis and other very serious side effect. And then he asks did you did you in regards to vaccine, do you consider your family to have it? So then I explain it depends on case by case, as my parents are more than 65 and they have some comorbidities. So I probably would suggest them to have it. But as my me and my other family, like my husband and my children, there is no data. So I would still wait for it, as I do not consider myself as a high risk and I do not expose that much. I mean, we are rarely, go outside for something. So then I think he convinced. So just I want to convey that things that, I think all of us need to know a little bit about COVID vaccine safety and efficacy. Even like for you guys, like, whoever not in the childbearing age, I mean, basically for all of you need to know, like, why the vaccine is like the anaphylaxis rate, side effect and all that. I think he wants to know that I know the, like, about the vaccine in detail, or like at least in general. So after that, I search actually. So, the vaccine is not, the Pfizer one did not talk about anything about childbearing age and is it safe, or is it anything like, there is no contraindication for pregnant or anything, something like that. So, like this is a very, very nice question I felt. And I feel like I was not 100% prepared, but I try to save myself, whatever I know.
Thank you so much for sharing, and excellent. Good luck. Any other points?
Thank you, Mulham and Somi and Dalia, for sharing the tips and your interview experience. That's really a good question about COVID. I think we should be fairly informed when we take the decision regarding taking the vaccine or not. And I feel like that's something personal. Yeah, so it is up to everyone. I do have a question for Mulham, just regarding to sending letter of interest. Do you mean by sending, you send like in 2 times, you repeat sending to the same programs, or just new category of other programs? Thank you.
Thank you, Laura, for the question. And no, I usually send to certain groups of programs. For instance, the first time I sent to 20 programs. It was a mix between affiliated universities and universities. The second time around, I did a similar mix, but in a different programs. I don't do the same, because then they would know that I'm sending them the same message. And if I will do such a thing, I would change the whole letter itself, how it's, the frame, I'll change it.
Gotcha. Thank you so much.
Thank you.
Good question to Malham again. What's the title if you are sending an email?
I'm sending, the subject is interested in your program, but in the brackets, I usually say the things related to the program. For instance, I'm in Baltimore. Now, I sent to the program saying I'm a Baltimore resident with no visa, or with visa sponsorship or something like that. So that allowed them to know that I'm someone who doesn't need visa. And at the same time, I'm a Baltimore resident, so I'm good for you. So if you are in a certain area and you know that there's multiple programs, I think that's good. As I had a response immediately from a program coordinator saying, you're waitlisted today. Yeah.
I really, I like that you put it into sections. So the subject's supposed to tell, it's like marketing. So you want to convey the message to the reader. It's supposed to be eye-catching. So your phrases, you want to put it in a way that's raise the attention for the reader. So if you want to put, as you said, the program offers visa, you can mention that you have a green card, so you removed some headache for that program. If you have a citizenship, you can mention that. Location, as you said, that's also important. Other things that you can mention about, like you can mention MSU fellowship or fellow seeking position. You can mention that you are available right away for open spots, because some students might cancel. So either any part of this sections in the subject will give you a unique selling point will be helpful to the program to look at the email, open it. So thank you so much, Mulham, and that's great. And you can play with it, so you can put one subject, then put a different subject using different things according to what programs interested in or what you think they want to open your email, for instance. Thank you. Anyone else?
Thank you, Dr. Nadir, for talking about the catchy subject for the email. Actually, an advice from, sorry guys, cleaning day. Is it too obvious, okay. An advice from one of my friends that for the programs in Michigan area, if you use like the MSU is more catching because it's very known there. And they were suggesting like even it's from their email, from your student email, maybe that's what apply to SOMI. That will give you the opportunity to get interviews from that area. So, and I actually did use this. I haven't got interview yet, but I had a reply in the same day, like for Georgetown or George University that I graduated from. So I put that in the subject line and I got a response the same day. I'm just waiting for them. So thank you.
I want to share with you, when I finished my first year, I was on basically the same boat like you. I sent my email or fax at that time, and I put that I was Harvard fellow or something like that, because I did 1 year postgraduate fellowship in Boston at Harvard University. So this really plays a big role if you want to add something catchy that will open the eye, and they will try to be intrigued and see what's going on with this candidate. But thank you. Anything else? Thank you, Lubaba and Mulham. Any other comments or addition? Anything to share, guys?
I want to share one point, which is I use my email personal of Kaplan. I think that might also help. So if you have the opportunity to use your work email, that makes it bigger for them. If you have Michigan State University or in a different institution, please use that, because they will look into it and then feel that, oh, he's actually working there. So we might give him an opportunity. But also, if you're not having this email, it's okay. Use our own email. Inshallah, it will work. That's the only one thing I want to share. And also, I want to say that I did change a bit in terms of the question, which is tell me about yourself. This itself, I changed the perspective of my answer. It was based on my CV. Now it's a bit changed into more less scripted process, where I first start by mentioning who I am, from where I come, and the distance from United States to Sudan is about 7,500 miles. And they start saying, wow, that's too far. So it becomes somewhat engaging from the start. I think it's better to have a story. Then I would share my family. I would say my father is so on, my mom is so on, and we come from here, and then start going in a sequence why I enter into medical school, and then enter into medical school. So it becomes more engaging, and they start asking me questions about that in every segment. So that's not my approach. Before, my approach was based on, in college, I graduated, that's it, I'm in the United States, this is my funny joke. So now still I play the funny joke at the end, but they are more engaging in between the sequence. I think that's a better option in terms of storytelling. It's better than a scripted process. And inshallah, that will be helpful, and inshallah, you'll get interviews soon. Thank you.
Thank you, Mulham, again. And I like the way when you talk about answering. So if you divide your answer, usually we tend to just answer the question as it comes. So did you go to school? Yes. It's just a reflective kind of rapid answer. I think you should practice on giving the answer into subsection, where you want to say yes, but before you say yes, you want to add something in the front and something at the end. that's personal to you. Everyone is different. So you want to add some story, as Mulham mentioned. So I think that will increase your chance of convincing the other person. At the same time, it will give you an opportunity to throw out some catching points where you can lead them to ask you about other part of CV or things that you want to also elaborate on. I think you want to sell yourself, so they have to be interested in you as a unique candidate. But thank you. Any other comments or questions or anything to share? So maybe we can go to the next session. Yesterday we had a good meeting, Khalid, Lubaba and I, with the statistic people, the director of the center and one of the students, PhD students who will analyze some of the data. So what we did is I thought we will discuss about the Sparrow data, and actually Lubaba corrected me. It's about the depression data. So we pulled some of the data, some of this of you change or enter the data from PDF file to Excel or Google Sheet file. That was helpful. So during the meeting, we discussed some points. Maybe Lubaba, if you want to share, or Khalid.
Yes, I can share that. Thank you so much. As Dr. Nadir said, it was a successful meeting. So we told them that about the variables that we're looking at currently for the abstract that has been, we can say, initially accepted, and we are waiting for they are waiting for the data analysis and the discussion. The team is going to help us finding the difference between last year and this year for COVID effect on depression, anxiety, and antipsychotic medication use. They suggested many things. Were asking about, can we compile all of the months, like the 10 months, it's from, or 9 months from March to October, or we can do it in a different comparison in different like month by month kind of level comparison. They will look into that and see some months maybe they don't have, like, the data is not very different. They are trying to give us graphs and compare to the time of the lockdown and how that impact the outcome at the nursing facilities. And actually the data is from the 3 nursing homes in Michigan area. The good thing is going to be compared to the national as well. So we're expecting to have like a good abstract and good results with their help of the analysis of the data. So currently we are almost having all the data from one of the facilities, waiting from the third one. And actually the second one, we do have the data, but there is some overlapping on the months that we are looking at. So we want to figure out how we proceed in that one. I think this is most of the stuff that we discussed yesterday. If Dr. Nadir want to add more. I think Khalid Adam is not available today.
Excellent. Thank you so much. Yes. So basically, we will give them the Excel sheet with the data for the 3 facilities, including the facility numbers, and compared to the state numbers, and then compare that to the national. And then hopefully we can figure things out and find some findings. If not, we will just mention the thoughts and the theory behind that. And it's going to be a nice thing to present. They suggested that to include the whole year. So compare 2019, the whole month from January to December to this year. And this time, we think with the data we have, we should limit ourselves just to the COVID time or period. We started here in the US in maybe March to collection date of October sometime, and then compare that period to previous year. Down the road, maybe we would think about increasing the time of the period from January to December. But for the sake of the abstract, I think we should limit ourselves for that. The other point I want to share is we have some money for analysis and for other stuff from the funds that we have. But the good news also that the program director from that center said she already talked to the dean or the School of Medicine, and they have also money to support her. So I don't think we will be spending money in this project. So we'll have some for future projects for analysis or any education needs that we will have in the future. So just an update. Any questions or comments?
Great point. Yeah, thank you so much, Dr. Nader. I do agree that we need to stick to the time that we suggested from March to October for other reasons that we are trying to see the effect of COVID. And as I did the literature review, what I tried to compare, tried to present, there is a difference in other papers that has been published, like I think within that time frame, or with the same effect of COVID. So from Europe and I think one paper from Africa. So I think, yeah, it's a good idea to stick to the time now that we are suggesting or proposing.
Excellent. Any questions or comments from the group or any update?
Dr. Nadir, I have a question for you. It is not related to that research, but as you mentioned a couple of weeks ago that in the app you have like uploaded some case or something by our name, and then we are supposed to review those and probably give you a feedback or something. So I mean, I was not very sure about that. Can you just explain it a little bit? Because when I go to the app, there is something called GRS under the faculty. So is that the cases you are talking about? Thanks. You are muted, Dr. Nadir.
Thank you. I'm going to share the screen with you guys and we'll go over this together. So, okay, how can we do that? Okay. So if you go to the app, all right, I'm going to stop the screenshot. I'll open the app first and then share it with you guys. Sometimes it takes time for multitasking. So as we get older, don't get older, but we are slow. So here we go. My computer also is getting older. So if you go to the last, I think, on the right side tab, so this is basically a task for each one of you. The goal is to know something about the geriatric, what some of them we call it geriatric syndromes, geriatric topics or conditions or things affecting the older population. So if you go to the right side bottom, you will find some task, I think. Yeah, here. It's listed by each one of you has one assignment or one slide document, like Google Slides. And in that document, when you open it, it has a presentation, the presentation about certain topics. Let's say I'm going to take you, Sumi, as an example, I think. You are one of the top, maybe. So this is the instruction. So if you find it, download basically the slides, and you can just practice presenting it as you wish. If you want to get some additional information, you can go to some of these resources if you have access up to date or family medicine association or any other resources that you can get. But okay. So if you go to this is it will list your slide here. If you open it, it will give you a link to the file. So you download this file, and it has the slides. It's you can use it as a Google slide, or you can use it as a PowerPoint presentation. And as we said last time, you can use Microsoft Office website so that you can use a coach while you're presenting and improve yourself. So for that, you can go to Microsoft. And then you can log in, create an account if you don't have one. And on the left side, you will find PowerPoint. If you open PowerPoint, you can upload this slide file to the web, and then you can open it and present it. In the presentation mode, you will have a coach kind of way of handling when you are talking. It will analyze how fast you are talking, if you are slow or if you are fast. It will analyze if you have a breaking, like points where you will say when you stop, or something like that. So it will just correct you or raise your awareness about some of the things that you do subconsciously while you're presenting. The other option I wanted you to do is I think you can record that using the Microsoft. If you cannot do it, you can use it with Zoom. You can create a Zoom meeting the same way we are doing and try to present it and save it as a file, video file. So far, do you have any questions or anything unclear about this? The whole slide, if you want to look at the subjects, and if you don't feel comfortable presenting one of them, you want to switch GRS slides, you can go to the list here. And these are the topics. Basically, dementia, depression, anxiety, cardiovascular disease, pulmonary disease, kidney disease, diabetes. So each one of you was assigned to one of these slides or files or topics for that matter. Does that answer your question, or do you have any questions for me, guys?
I have one question, Dr. Nadir, regarding the PowerPoint coach or something. I tried, I didn't have Microsoft Office at the time, so I didn't look into it when we were talking about that in the past. But now I have the Microsoft account, but I don't see it exactly. In the when I open Microsoft PowerPoint, I see like there's like they can show the rehearsal time when I press a slideshow. There is like rehearse timings. They put just a timer with the slideshow, or they have another option which is record the slideshow. But I couldn't find specifically like the coach part where to find that.
If you download the Office in your computer and you are using PowerPoint, is this the way you are doing it?
Yes.
No, I don't think they offer it into that. I think they offer it in a temporary feature. It's an online. So go to the online Microsoft Office, use the website presentation, and I think you can find it there. And it will analyze that right away for you after you finish.
Okay, all right. I will check. I will try that then. Thank you so much.
You're welcome. Any other question, or did I answer you, Sumi, for your question?
Yeah, I got it. Thank you.
You're welcome. Any other questions? In the app also there is a video about tips for using this kind of Zoom and some other tips for using PowerPoint and maybe Google Slides, I'm not sure, but if you look at if you have time, look at some of the videos. It may help you get some improvement. Everyone of us has some room for improvement, so. And you can add some videos. Let's say you are working on leadership, you want to get some more information and you found some video, good one, there is an option for you to upload some links to the video so that you can share with others. Same according to the topic you are assigned to. Let's say you are talking about anxiety and you find some presentation or slideshow or something about anxiety and you really want to not copy all that, you want to share that, the whole video or slideshow with the group. Also, you can just upload that as a link to a video or link to PDF or some other types of files. You can add that to the presentation or to the app. Are the instructions clear for you guys as far as what you want to do, how you're going to do it? And
Yes, for me. Thank you.
Yes, that's clear. Thank
you. Yes, it's very clear. Thank you.
Yeah. So my goal is to, for each one of you, you will be the expert in that subject or topic and try to rehearse, do it several times. You will be comfortable using the PowerPoint, using the internet, and at least you will have some feedback for yourself about what you can improve on. Try it again and see how you do. And after you're done with the final version, you will have knowledge about geriatric population on that topic, and you will have some experience with using the presentation. Hopefully this will help you in the future. The second part is when we have every one of you done, hopefully within the coming week, by the end of the year, I want you to each one look at the other videos, how the other people presented their work, and you can add some comments, positive or some critique or some suggestion for improvement, so that you can have, we call it peer review, where you give feedback to each other so that we can increase our chance of improving each one of us. And at the same time, we will learn about other topics. Thank you.
Yeah, I think that's a good way to, because I mean, all of us gradually, eventually all of us has to, present, preparing the slides, and like, like it will improve our presentation skills as well as our like communication skills, and also the how to prepare slides and all that, because I'm sure like during residency and fellowship we have to do a lot of these things, so we'll become more confident by that way.
That's correct. Excellent. Any other questions or any other comments? Anything to share?
Yes, I do have a question regarding the project. If no one has any question regarding using of Microsoft or what we need to do.
Go ahead, go ahead.
Okay, yeah, so for the variables that we are using currently for the project is, as we said, the anti-psychotic medication, anxiety, and depression itself. So for the anxiety is not mentioned as a variable in the Casper report. It's just like
it's my fault.
Anxiety medication.
It's my fault. I thought it's there. I didn't look carefully into the table, so don't mind me. We will talk just about the anti-anxiety medication, antipsychotic medication, and depression.
Okay, so when we resubmit the data, we omit the anxiety part from the abstract.
Correct.
Okay.
Correct. Yeah, we can mention it in the discussion that the treatment of anxiety, if we notice there is increasement, that means we assume anxiety increased, and this is why we treating anxiety.
So does that mean we need to enter the data from the anti-anxiety medications?
Yes, please, if you can have that, that would be great.
Okay, so my second part is that for the anti-anxiety hypnotic, there is prevalence and percentage. Which one we should enter? I think it make it easier if I can share my screen so we can talk to the document.
Go ahead.
Yeah. Okay. Let me share. If you can see my screen here, this is, for example, the Borsham Health Center. We do have anti-anxiety hypnotic prevalence and percentage. So which of these we should enter?
I think we should enter both of them. And then when we do the analysis, they will do them separately and see if there is any.
Sounds good. And we can add a note at the end of the thing. Perfect. The other question is that for the same, in the same document, for example, here is the reporting period between October 19 until April 6 of 2020. So we don't, in our project, we're not looking for November and December, for example, for the year of 2019. How should we proceed on Borsham Health Center?
So this kind of a good question and tricky question, because I think if you go to the third line, report run period, instead of the report period, that will give you around the date of the data collection.
Yes. You are muted, Dr. Nadir. Sorry.
Yeah, usually the report, I think, is run monthly, but sometimes they include a few months before the monthly report. It's not like from January 1st to January 31st, like that every month. They do it, I think, previous 3 months. So in this study, we wanted them to get month by month so that we can get the comparison. But in real life, I don't think they report that way. And that was a question on the discussion yesterday. What are we going to analyze? Are we going to analyze month by month, or period by period, or the whole 3 facilities against the other state and national data? I think for our purpose, I think we can combine. If we need to extend or elaborate, then that might be, because the data will be small if we take it month by month. If we have more data, then it will make sense to do it month by month. But for now, I think we will enter the data, let them analyze it as a whole thing, and give us the report. Does that make sense?
Yeah, it does make sense. But for this specific PDF, for example, we do have November and December included in this report time. So another thing that I'm thinking about, maybe search the other document and try to find a reporting period that does not include November and December, just not to bias the outcome or I mean the analysis. What do you think? I can look into the PDF and see, because here it's November and December included, which we're not looking at on the 2020.
Yeah, so let's look at the whole data and see.
Yes, okay, let me see if we can do that. So for this one is November to April, December to May, January 20 to 2020.
Can I add something?
Yes.
Yes, please.
Yes.
Yeah, so what I was thinking, like if, see the COVID started in March, right? I mean, like mathematically it started in USA in March. So if we have data from November to March or something, we can categorize as a pre-COVID, during COVID and post-COVID, something like that based on that data. So how it like deteriorate, like, you know, from pre-COVID period to COVID period to post-COVID period, something like that. Like how, you know,
I agree with you with the two parts. The third part, I don't agree with you because we are not there yet.
Yeah.
Unless you are reading the future. But yeah, so we can do the pre and then the post. So the cutoff will be data from March onwards, and before that will be pre. So yeah, thank you.
Good plan. Thank you, Somi, for the idea.
Okay. I mean, I mean to say basically post-COVID is like after vaccine, like, you know, after the whole community get vaccine. So, I mean, not now, probably 1 year or 2 years from now, we can compare that. That's a prospective trial, I would say, prospective, you know, like research.
Great idea.
Excellent. Thank you. Yeah. Excellent. Thank you so much.
Thank you. Okay, I will look into the PDF and share with the team how we can proceed and find out the pre and post. Or
may I suggest something? I'm sorry. I'm not sure if this is gonna work, but just like something to consider. For example, we have data from the 1st of March until the 31st of August. So can we use this as a template to make, like, to get the idea about the months afterwards, like if you know what I mean, like just try to compare the numbers ourselves. For example, for falls here, the number was 25, and check here the month it was like from April to, I see it. I think it's not gonna work because it's completely different. I thought we can like just use the available 2 or 3 tables to get the information about the whole duration, but it's not gonna work because the start point is not the same. The start point changes and the end, like the start period changes and the end period changes as well. So
yeah. Another idea, if we can find, this is February. I think, yeah, addressing it as a pre-COVID might be helpful, as Tommy suggested, if we couldn't find the data from that time. I mean, just like specific from March. I think those are my 2 questions regarding the projects, and yeah, I will reach out to the team and try to finish out the data entry by maybe tomorrow evening, Sunday evening, if everybody's willing to or have the time to do that. And then by Monday morning, we can submit it to you, Dr. Nader, to share it with the team.
Excellent.
Thank you.
Thanks for sharing. Thanks for the comments, everyone.
Thank you.
So for the other projects, we still waiting to hear from them. Hopefully we'll hear good news. If we don't, I think the next step will be to work on, sometimes what I do is change the title a little bit and to try to figure out where else we can submit it to. There is a American Geriatric Society. The deadline is soon, but there are other societies or other bodies that we can submit to, so we can think about other groups in the future. So by next week, the week after, if we don't hear anything, maybe we can think of resubmitting it to some other meetings and see. Any questions?
Dr. Nadi, the like American Geriatric Society, is it the deadline like January somewhere?
I think it's December, end of December. I'm not sure. I have to look into the website.
Okay. But we'll be submitting the same abstract, little bit like wording, rewording it, right? Something like that.
Correct. It's just, we assume that it's not accepted. I don't know if they have a deadline to submit the response. I'm not sure how it works, but this is just a thought process of if we accept it, that's good. If we are not accepted, then we should think about how we can modify it to submit it to other places. And then the third plan is to think about going right away to publish it as a paper or something. But I think it's easier to go through abstract submission.
So in that case, I think now we have the data, so we can resubmit it with the data, right?
Yes.
Correct. So for this project also, the biostatistician, that group can help us, right? Like
definitely. So we open the channel, so now we can say, hey, we have this data and this table and the other table and this. So we will work together. Hopefully there will be collaboration between both of us.
Okay.
I think they will help us. They're very excited, sir. It's a COVID, and COVID is a hot topic now, so they showed some excitement yesterday.
Definitely, I agree. Also, I want to update you. I did the presentation about the fellowship to the department and to the research group in the department. Both groups are very excited, and they gave me some suggestions for the future. So down the road, we can share this in details and see your input, but it has a good impact on the faculty here in MSU, at MSU in Lansing.
Great, thank you.
Okay.
I need to ask you a favor. Whoever didn't complete, there is a second survey on the app. If you can have a minute to complete that. And again, if you send me the people who are involved in each project, like the team, that would be also great, just to keep track of who is involved in what. If you have any questions, send me an email. Any final comments, questions, concerns, or should we just plan for the next week?
Hello, I have two questions. One of them is not related to today's topics, but first I would like to thank my colleagues for giving us their interview experiences. And I would like to ask Dalia, in which specialty she interviewed the last two interviews. And my second question is for Dr. Nadir. Like sometimes I receive invitations for working on a peer review or reviewing article for others. Like I just want to hear your opinion about that. Is it important? Is it gonna benefit me on my career? And if I can add that on my CV, like that I reviewed how many, much papers, and how can I write that? Thank you.
I'll start off with the answer for my question, for your question. Mine was family.
Okay, thanks. Yeah, that's what I thought.
Excellent. Thanks for the questions. So as far as reviewing, you have to think about it in two ways. If you review as just part of doing what you are doing, like reviewing literature and doing this and that, and presenting it to the department or presenting it into your work, that's one way. If you mean to be a reviewer for an article in a journal, let's say the journal send you a request to review an article that was submitted to them, then you will be on the board for reviewers or something like that. They can call it differently, but you will be a reviewer for an article that's submitted to a journal. For that, it's a good experience, and you will know how to analyze the they call it manuscript when they submit it, and you can critique or ask for more clarification, something like that, from the manuscript, and for the authors to amend or change or get more information. This can help you in the future. I'm not sure if it will help you in your application right now. Maybe, maybe not. If you put it in your resume that you are a reviewer in a journal. If it's a big journal and you say I'm one of the reviewers for this journal, definitely it will put you at a higher rank compared to others. But I think from the point where they want to look at you, they want to see how are you involved in the research, how are you involved in publication as far as you contributing to the literature. So if you show them that you are working hard on this, I think that will be at this level beneficial for you. When you become an attending and join an academic setting or institution, then the other part, when you will be a reviewer in a journal, that will benefit you at that level. I hope I answer your question.
Yes, thank you.
Can I add something?
Yes.
So Ryan, I'm not sure, so your question, like I do something close to that, the question you asked. As my, where I work, my supervisor is a associate professor for oncology. So he is the editor and reviewer for American Association of Clinical Oncology, as well as American Urological Association. So most faculties are always busy with patients and all that. So if he is overloaded with, let's say, 10 journals he has to review in a month or so, so sometimes he, as I have a research background, so he wants me to co-review that. He wants, let's say he gave me that journal and then say what is your comment about it, and search the same related topic to PubMed and see what they published and what is what is new for this new what is the new things in compared to what they have published in regarding to that topics, and is there anything new message they are trying to convey. So, and then I did these things almost last 6 months, I review almost 30 paper. So, and then I asked him like, how should I put in my CV? Because I cannot put that as a reviewer because I'm not the reviewer. I think I'm not allowed either as he is a faculty. So he asks actually, to the journal association that he said my fellow is helping me. And I mean, he kind of explained that's how she's helping me. And, that's her role is. So how should she's reviewing, so how can she put it in her CV, or what should be her role? So now I put those things as a co-reviewer with my like supervisor. My perspective, I'm not sure how does that help for residency application, but my own experience, it is very helpful in regards to your research analysis, because what when like, see, let's see, if I want to submit a journal, like a manuscript regarding this COVID, so I know what are the things already published, and what are the new message I have to convey them, like it is not already invented or something. If I do not convey any new things, there is the possibility that my manuscript got not accepted. And so like, I mean, doing this, it is a great experience. And as my mentor also, like my supervisor also mentioned, it might not help right there for residency, but it is helpful if you are planning to pursue your career as academic institution. So today or tomorrow you will be a faculty, and it will be helpful. And also this is like American Urological Association is a big association, I guess. So like I also, they have like yearly yearly manuscript and book chapter, so they put my name also, that acknowledgement. So those things you can add. So I'm just telling, I want to share my experience as this I feel like this is important to decide for your question. Thank you.
Yeah, that's a good answer. Thank you, Somi.
For sharing. Thank you, Ryan, for the question. Any other comments, or shall we discuss about or suggest for next week meeting?
Yes. Actually, I do have a suggestion for depression and falls. Sorry for bringing you back. So I know the main objective is to compare depression and falls, COVID and pre-COVID. But if we can compare the months, for example, depression and falls in March and now, it could give us something interesting. For example, for instance, if maybe anxiety has peaked with the start of COVID, maybe depression peaked at the end after 6 months as they get frustrated and so on. So, what do you think?
I completely agree with you. It's a good suggestion. So what we suggest yesterday with the group for analysis is they're gonna look at the data, and they're gonna look at what we have, and then compare it. To do it month by month, they will do that and see, but they will combine also the three facilities together to get a bigger number, and then will tell us what they found and take it from there. There are other things and they suggested to add, but as I said, for the limitation for this project, I don't think we should go all, they call it 9 yards of cold thing. It opens the door for us to think about things if we want to expand in the future. That's an option. But for this project, I think we should limit ourselves and see what we have in the data and present this data. Thank you for the suggestion. Excellent. All right. Anything else? Somi has some suggestion for next week. Go ahead, Somi.
Okay. Actually, I'm not sure, like Dr. Nadir sent us a link for AAAP discussion. So I was in that discussion last, I would say Thursday, or I think Tuesday or Wednesday. And that was a very good discussion. And they are talking about basically like post-COVID and how primary care, will be changed forever. So they explained like the role of artificial intelligence in primary care, it's like globally. So I was very interested in that. I listened that topics, and then I feel like we all need to know about that. This is a new kind of technology, and probably we need more information. I'm not sure any of you was there for that for that Zoom conference. But I listened, and I feel like this is interesting. And if all of you agrees, I may present that. I'll try at least. And I asked in the WhatsApp group that anybody wants to join, and Rua actually I was interested, and she contacted me first. I think some of you also interested, but as she contacted me, she's the one who contacted me first. So I thought like I would give her the opportunity. Unfortunately, she has on call today, so she's not here. But she said like, we'll decide like how we will proceed with that.
I think it's a good idea. I think COVID is here, so we focus on COVID. But for the future, I think we should think about technology in general. Artificial intelligence is one part of that. Telemedicine is another part of that. So the field is developing fast, and technology is developing fast, and wearable remote monitoring. So these are things that it's fruitful area if we think about it as far as research. And if you want to be unique when you apply to residency, or even in the future when you are a physician, you will definitely face this thing. So if you are ready from now, I think it will be beneficial. So I agree with you. Perhaps you, Ru'a, and if someone else interested to present with you guys, again, same way, half an hour or so, and then we'll open the discussion, and then we will try to answer some of the other aspects of the fellowship. Anyone else wants to add anything, suggestion-wise?
This is me again. So it's not a suggestion, but just a follow-up on our fellow meeting. We had a very successful meeting last week, and thankful for Ali. He has been elected to be our first leader for this month, and he's for the leader for our subgroup as well. We discussed many things, from them the abstracts and how we set up agenda for Saturday. So Ali is going, and thankfully he sent us this agenda in the group. We are planning to hold more meetings in the future, just to rotate and find leaders. So just wanted to share this with you. So it was a very successful meeting. So Ali is our speaker for this month, Speaker of the House.
Excellent. Thank you so much. So if each team send me the leader of the month or speaker of the month, so that would be great. And for those who are leaders for this month, if you have questions you want to share with me, I'm available. We can do a very quick Zoom meeting or discussion. See if you have anything that I can help you with, you guys. That would be great. And for the update, and then you can disseminate the answer or the information to the team. I think that will be a good way of communication to make life easy for you guys. Good. Thank you for that, Detleva. Anything else?
Dr.
Yeah.
Go ahead, Ali.
Go on, Sumi.
No,
okay.
No,
go ahead. Dr. Nader, after this meeting, I want to check your availability. When meeting ends, to discuss leadership things. So
sounds good. I will stay with you.
Okay, Dr. Nadir, like, yeah, I feel, I think all of the fellow, we feel that if if as I think in the app also you selected, like you put from each of the team there is a month leader for each team, so we can follow that as well for our group, like as YOLO group. Like I think I was selected for this month of December, and then followed by Mulham, and then Marwa, and then the other person, so which is okay with us, I guess, at this time point. And I can do even like end of first week of January, as Mulham has some conflict until January 1st. And so my another suggestion is, like, for our discussion, I think all of the leader from each group, we will send the meeting agenda for all the fellows, so it will be easier for all of us to understand like what is going to be discussed today and prepare ourselves if we have some questions. So this is one thing. And second one is, like, can we split this meeting, like half an hour probably, like, something, and then last half an hour probably a case presentation, like the way we did today. So by that way we can cover like research and like case presentation, and if we want to discuss something like research presentation, something like that. So that's one suggestion, if everybody agrees with that.
Excellent, excellent. So why don't each leader in the team go back to the team and discuss this idea and see what they come up with. As last week we discussed with Lubaba, if all of you need something or agree on something, that would be great. It's kind of what we want you to benefit at the end of the fellowship. Clinical is something that we really want to address, so that's a good thing. The only limitation we should think about is not everyone is available the whole thing, and if most of you agree, that's well and good. If most of you will be limiting this meeting to 2 hours or so, today we went through like maybe 3 hours now more, then it's up to you. If you don't like long meeting, most of you, then we should reconsider that. Maybe the thought process will be like we can add a different meeting, let's say Sunday meeting or some other day meeting according to your availability, and then set that part for clinical aspect. Because sometimes we cannot cover all the 3 research, clinical, and then the interview tips and other questions as far as what's going on. So just discuss in your groups, in your teams, and come up with suggestions or plans. Great, thank you so much. So for next week, Sumi, Roa, and if someone else, or maybe the 2 of you, can present, and then see what else you want to do during that meeting. Hopefully we'll have some update about products, and then we'll take it from there. Hopefully by the end of the week or next week, the week after, if you practice, every one of you, and for the leader, if you can encourage your team member to just push them to finish, repeat and make sure they are done with a deadline, remind them. That would be great, and hopefully by the next year when we start, you will have a feedback, each one of you, about what you finished as far as the task you are assigned to. Great. Any other feedback, any other questions, anything else? For those who did not submit a reflection or feedback about the fellowship, I really appreciate if you have a couple of minutes to do some thinking, reflection, see what, when you joined the program, what your expectation, what actually happened, what you still have to do, and then if something happened, how to fix that in the future. So that will be a great thing to do. Thank you, everyone. All right. Anyone wants to add something? I'll count in Spanish. Uno, dos, tres, nothing. Then we will see you next week, hopefully. We'll hear good news about you guys, and I wish you good luck. Thank you. Thank you, everyone.
Enjoy the rest of your weekend. Bye-bye.
Bye. Thanks.
Thank you, Dr. Nader. Have a good weekend, everyone. Bye.
Thank you, everyone. Goodbye.
Thank you, Dr. Nader.
You're welcome. Thank you.
Thank you all.
Thank you and bye.
Bye, guys.
Go ahead. Oh, they're gonna go swimming? Okay, swimming. Okay, we can't.
Hello, Ali. You're muted.
Yeah. Can you hear me now?
Yes. Yes.
Yeah. So, Dr. Nader, I want to talk to you regarding leadership and so on. So, I don't know if you are available this week, and what should I do, and what the team is expected to do, and so on, to follow on that. So, I don't know what available time do you have?
If you have a minute now, we can talk. Are you busy? Or you have something
Yeah,
to do?
actually, I do have something to do now, but
Sure.
I don't know if anytime else better, I think.
Tomorrow, are you available?
Yeah, sure.
What time? What time
Sure.
tomorrow?
All day, I don't mind.
Okay. Perhaps noon time here in New York time, which is it 8 o'clock in New York time? I don't know.
Yeah. So 1 p.m. Eastern time, right?
Okay, 1 p.m. Yeah.
What did you say? You say 12.
I said
12 p.m.
12.
Right?
12. Yeah.
Yeah.
12 is okay with you?
Because you said 8, and then it's
no,
7
12
o'clock, 7 hours difference.
Yeah, 12 in
12
New York time.
is good. Yeah.
And your time will be 7. I don't know. Yeah. So 7 o'clock with you. 1 o'clock, noon o'clock, 12 o'clock with me. Yeah.
Yeah. Okay. So
okay.
Then
I will send you a link.
It will be.
I will send you a meeting link. All right.
Okay.
Any other questions?
Okay.
All right. Thank you.
No. Thank you.